Hello, everyone, and thank you for joining us today. My name is Heather Phillips, Research Director with the National Center on Domestic Violence, Trauma, and Mental Health. Today's webinar is SAMHSA and ACF Information Memo on the intersection of domestic violence, substance use, and mental health, research, resources, and recommendations. Today's presenters are Shondell Dawson, Director, Division of Family Violence Prevention and Services, Family and Youth Services Bureau, Melinda Baldwin, Special Assistant, Office of the Director, Center for Mental Health Services at SAMHSA, Kenya Fairley, Supervisory Program Specialist, Division of Family Violence Prevention and Services, Family and Youth Services Bureau, Carol Warshaw, Director, National Center on Domestic Violence, Trauma, and Mental Health, Gabriela Zapata-Alma, Director of Policy and Practice for Domestic Violence and Substance Use, National Center on Domestic Violence, Trauma, and Mental Health, Beth Collins, Domestic Violence Program Specialist, Colorado Department of Human Services, and Elliot Burkhead, Deputy Commissioner of Programs and Policy, West Virginia Department of Health and Human Resources, Bureau for Behavioral Health. Before we get started, I would like to go over some technical details of the WebEx software that we'll be using for today's webinar. Many of these details are explained on the Using this Webinar System tab in the center of your screen. You can switch to this screen from the slides by clicking down on the arrow next to Using this Webinar. Please be aware that your screen might look a little different depending on whether you're using a Mac or a PC. So on the right-hand side of the screen, there are multiple boxes. Third from the bottom is the chat feature. You may have to click on the chat cloud icon at the bottom center of your screen to open your chat box. This feature will allow you to provide feedback and share resources with your fellow colleagues, as well as get in contact with the trainers if you have questions regarding the training content. You may contact Carla Alegria, also with the center, if you have questions troubleshooting the WebEx software. To do this, click the down-facing arrow and select the person you would like to contact. You'll see a lot of options, but for this session, you'll want to select all participants if you would like to respond to a question from the trainer or to contact center staff at any time during the session. You should click on Carla Alegria to privately contact her if you are in need of troubleshooting the WebEx software. So let's test this chat feature. Will everyone please go to the chat box, click on All Participants, type in where you're calling from, and then press Enter. Oh, wonderful. I'm seeing people from all across the country. Just saw Allentown, Pennsylvania, Atlanta, Georgia, Des Moines, Iowa. Wonderful. Thank you all very much. While folks can get a lot out of the chat feature, there are times that it moves really quickly and can feel distracting. If this is true for you, feel free to minimize the chat box by clicking the arrow next to where it says Chat. You can always open it again with the same arrow if you choose. We will be providing live captioning during this webinar. Below the chat box, there is a media viewer box. This will contain the captions. If you do not want to see the captions, click on the down-facing arrow next to the word Media Viewer, the same way you might if you want to hide the chat box. Time permitting, Gabriela Zapata-Alma will be moderating the Q&A towards the end via the chat box. At the very end of the webinar, you'll be taken to a brief survey. Please take a moment to let us know what was useful and what could have been better. If you get disconnected at any point, return to the email you received with the original webinar link and re-enter the training. Sometimes the sound cuts out due to internet connection, so feel free to call back in if that is a problem for you. And if you're experiencing technical difficulties and are unable to contact Carla Alegria, you may call WebEx tech support to resolve any issues. That phone number, which I'll post in the chat box, is 1-866-229-3239. Again, thank you for joining us today, and I will now turn it over to Kenya Fairley.
Did Kenya drop off? Shondell, are you able to speak? It looks like Kenya dropped off.
Can you hear me?
Good afternoon, everyone. I am Shondell Dawson, Director of the Family Violence Prevention and Services Program, and I'm so pleased to be joining you all this afternoon. Domestic violence and substance use and mental health are all issues with major consequences that impact a large number of domestic violence survivors and families and people all across this country. And while historically addressed separately, many people seeking domestic violence services are also in need of mental health and substance use treatment and recovery support. At the same time, there's a significant number of people who are accessing behavioral health programs that are currently experiencing domestic violence or have experienced domestic violence or have some form of intimate partner violence as part of their trauma history. Increasing collaborations and coordination between systems and providing services to individuals experiencing multiple forms of trauma, whether they're accessing behavioral health programs or domestic violence programs, can help us all ensure that individuals and families have the support they need to heal and address the myriad of challenges facing them that may be standing in the way of their safety as well as long-term recovery. The information memo that we are here to discuss today reflects a joint effort between SAMHSA, the Administration for Children and Families, as well as the Family Violence Prevention and Services Program, and the National Center on Domestic Violence, Trauma, and Mental Health. Our goal is to address the unmet needs of survivors and their families who are experiencing the mental health and substance use related effects of domestic violence, as well as those who are experiencing domestic violence who may have never reached out to a domestic violence service provider in the past. The information memo highlights the prevalence of domestic violence among individuals receiving services, and it talks about strategies for how we can come together to forge stronger partnerships on behalf of families. This webinar is going to give you all an opportunity to learn more about not only existing resources and strategies for improving those collaborations, but hear more about different types of tools that you all may be able to offer to your colleagues as well as to your families in terms of improving access to services, support, and resources. We're looking very much to doing all that we can to support your work. There are some tremendous experts who will be talking with you all today, and I am very pleased to welcome you to this webinar. And I would now like to pass the floor to my colleague, Melinda Baldwin, who is going to give an overview of SAMHSA and offer welcoming remarks.
very exciting for SAMHSA to be a part of not only this webinar, but also the collaboration with all of you and also with FISB and the National Center. So just to give you a sense of SAMHSA's role is that we lead the public health effort to advance the behavioral health of the nation. And so how we do that is through 4 centers. The Center for Mental Health Services, which I'm a part of, and this center leads efforts to promote the prevention and treatment of mental disorders. Congress created this center to bring hope to adults who have serious mental illness and children with emotional disorders. The Center for Substance Abuse Treatment is one that focuses on community-based substance abuse treatment and recovery services for both individuals and families in every community across our nation. CSAT, as we affectionately call them, provides national leadership to improve access, reduce barriers, and promote high-quality, effective treatment and recovery services. The Center for Substance Abuse Prevention, which is known as CSAP, is really to look at prevention activities and to improve behavioral health through evidence-based prevention approaches. And then, of course, there is our statistical arm, which really looks at behavioral health statistics and quality, thinking through, behavioral health statistics as those that are designated through our Office of Management and Budget. So when we think about doing that work, SAMHSA does it through a variety of discretionary grants and block grant programs. But specifically, when we think about this collaboration, it fits in with one of our 5 priorities in our strategic plan to advance prevention, treatment, recovery, and support services for those individuals challenged with substance use. And those are particularly supported by our guiding principles, which look at supporting the adoption of evidence-based practices, ensuring that everyone in the community has access to a full continuum of services for both mental health and substance use disorders, helping and engage outreach to clinicians, grantees, patients, and the public in general, collecting data, and also recognizing that the availability of mental health and substance use disorder services are integral to everyone's health. So we're very excited to be able to share our work today. Next slide, please. But what's really important when we start talking about the intersections, talk about intersectionality, is we're talking about that interconnected nature of social categories, and often we think of them in silos, such as race, class, someone who's suffering from interpersonal violence or someone who has a mental health disorder. But today we're challenging all of you to really think about those spaces in between, where families and individuals are challenged by both sets of issues. And so in order to do that effectively, I'd like to just kind of begin our presentation with some definitions, because what we found in our work is that when we're working in those spaces, that it's important that we're all on the same page. So when we think about trauma, we think about trauma here at SAMHSA as something that results from an event, a series of events, or a set of circumstances that's experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on that person's functioning and mental, physical, social, emotional, and spiritual well-being. So that's really, how the person themselves is experiencing it. But when we think about trauma-informed care, we think about a larger adoption of those principles and practices that actually promote a culture of safety, empowerment, and healing. And so based on what we know about the prevalence and impact of trauma, it is incumbent upon us and necessary to ensure that there's a widespread adoption of trauma-informed care in the organizations that do such great work as yours do here. So we're really excited to be here, and welcome.
Hello, everyone. This is Kenya Fairley. I'm testing out the audio to see if you all can hear me. Great. So thank you so much for that. I apologize earlier for the technical glitch, but I would like to welcome everyone to the webinar and say thank you both to Melinda with our colleagues at SAMHSA and also to Shondell Dawson, my supervisor here in the PHPSA program, for picking up and doing the welcome earlier. And also, of course, a great, wonderful welcome to everyone at the National Center on Domestic Violence, Trauma, and Mental Health. So I'll make a few remarks about the PHPSA program, and then I'll pass it back over to Shondell, who wanted to talk about some of the great work that we've done over the past 35 years or so. Here in the Family Violence Prevention and Services Act program, we're located in the Administration for Children and Families, in the Administration on Children, Youth, and Families, and the Family Needs Services Bureau. The mission of the Family Needs Services Bureau is to support the organizations and communities that work every day to put an end to youth homelessness, adolescent pregnancy, and domestic violence. We truly believe that we can get to a future in which all our nation's youth, individuals, and families, no matter what challenges they may face, can live healthy, productive, violence-free lives. So I just wanted to say that quick welcome, and I'm now going to pass it back over to Shondell to tell you more about the Family Violence Prevention and Services Act and the great work we've been doing in our program.
Thank you, Kenya. For 35 years, we've worked across the Department of Health and Human Services, the Administration for Children and Families, as well as with our colleagues in the Family and Youth Services Bureau, to forge partnerships between health, behavioral health, and social service agencies on behalf of domestic violence survivors and their families. When PHPSA was first passed in 1984, we were the first federal legislation to support domestic violence shelters and services. That funding over the last 35 years supports a broad network of shelters, of tribally based domestic violence programs, culturally specific organizations, national resource centers, as well as national domestic violence hotlines. In 2018 alone, we served 1.3 million people, which equates to over 800,000 women, 300,000 children, and 84,000 men. Our funded grantees, both in the state or on tribal level, also provided over 9 million shelter nights in 2019 alone. We know that PHPSA-funded programs are one important pathway to access safety, shelter, and supportive services, but we strive to partner across the Department of Health and Human Services to coordinate with our colleagues in SAMHSA, as well as our colleagues in the Children's Bureau and Office of Head Start and Child Care and Office of Family Assistance, to ensure that no matter the point of entry for a family, individuals can get connected to domestic violence services, safety planning, and trauma-informed support. The partnerships that between state PHPSA administrators as well as state mental health directors are crucial to our growth and evolution of how we continue that focus and that commitment to the families that we serve. We're very invested in doing all that we can to provide support around interventions and multi-generational programming for the millions of adults, children, and youth who are seeking our services and struggling with the impact of domestic violence, its mental health impacts, as well as if there are struggles and challenges with substance use. Through our partnerships with SAMHSA, we're striving to ensure that there's support across systems, that we're reducing barriers for services and for children. And through the collaboration, we're doing our best to advance the important work that you all are going to do on a state level as well as the local level. We fund a network and infrastructure of training and technical assistance providers who can help you all and be important partners as you think through the complexities of the social needs, the health needs, the behavioral health needs of families that are experiencing domestic violence, that are struggling with substance use, and may have challenges with mental health. All of that training and technical assistance that's funded by PHPSA is available for free to grantees and to the general public. And we have a tremendous partner in the National Center on Domestic Violence, Trauma, and Mental Health. For over 30 years, Dr. Carol Warshaw and her team has really led this deepening and understanding of trauma, of substance use, of opioids, and coercion, and what that means for those who are struggling not only with domestic violence, but sexual violence, dating violence, and child maltreatment. there are a incredible knowledge base, both for understanding what the clinical needs are and what the non-clinical needs are of domestic violence survivors, and can talk about the breadth of research and understanding of different types of interventions and how to best work to support those that are experiencing increased safety and challenge needs around domestic violence, or maybe had past experiences of adverse childhood experiences, including experiences with domestic violence and sexual violence. Over the next few minutes, you will hear directly from Dr. Warshaw around how the National Center on Domestic Violence, Trauma, and Mental Health can be important partners to you all, can offer training, and can discuss the current research and our understanding around clinical and non-clinical interventions. Please know that the PHPSA program stands in partnership with you to do all that we can to support your work, to nourish and help these collaborations flourish, and to make sure that you have access to the most up-to-date, best available resources you can that are available to be able to support your work, to help you lead innovations. And I'm looking forward to a year from now to hearing about all of the wonderful things that you all are going to do together. Thank you so much for your time. Thank you for your investment, and thank you for joining us today. I now would like to pass the floor over to Dr. Carol Warshaw.
Thank you, Shondell. I'm Carol Warshaw. I'm the director of the National Center on Domestic Violence, Trauma, and Mental Health. And I also want to introduce Gabriela Zapata-Alma, who's our Director of Policy and Practice on Domestic Violence and Substance Use at the National Center. You know, our center has been, we're so pleased to have worked with all of you on this, on the information memo, and to be doing the webinar with all of you today. You know, we've been working for, as Shondell, as you said, for many, many years to build collaboration between the domestic violence, mental health, substance use, and trauma fields. And we started out, the way to do that was bridging those gaps with trauma theory as an initial bridge, first as a Chicago-based initiative, and since 2005 as the PHPSA-funded Special Issue Resource Center on these issues. And as you said, Shondell, we offer a wide range of training, technical assistance, resources, and also do research and policy development. And we are really looking forward to working with all of you on kind of building and supporting and nurturing collaboration across fields over the coming years. We actually see today's webinar as a start, a launching off point to build and support the collaboration that we'll be talking about at a national, state, and local level, and to foster the development of policies and practices that better address the needs of survivors of domestic violence, sexual violence, lifetime trauma, and their families, and ultimately our communities. So I'm going to start off by highlighting some of the background information that's contained in the information memo to set the stage for the recommendations that Melinda, Kenda, and Shondell will be sharing with you later on. So in our initial conversations that led to the development of the information memo, it was clear that large numbers of people being served in the mental health and substance use disorder treatment systems had experienced domestic violence in the past or are currently experiencing DV at the time they're seeking services. And as you can see from our new infographics, women seen in mental health settings report very high rates of intimate partner violence, on average 30% of women in outpatient settings and 33% in inpatient settings. Some other studies have found that in inpatient settings that lifetime prevalence rates of severe intimate partner violence range from 30 to 60%, with women experiencing higher rates as compared to men. In addition, there are general population studies that have found much higher rates of domestic violence among people experiencing a quote-unquote serious mental illness, and studies of women who experience a serious mental illness have found very high rates of DV. We also see that studies conducted in substance use disorder treatment settings also find very high rates of domestic violence victimization among women accessing those services. And you can see 47 to 90% lifetime abuse and 31 to 67% within the past year. And one of the data on the 90% rate was in a methadone clinic, study done by Albaso and Louisa Gilbert. And for LGBT and gender nonconforming young adults experiencing intimate partner violence is also associated with higher rates of mental health service use. We also know that domestic violence has significant mental health and substance use related effects. And research conducted over the past 35 years has consistently shown that being victimized by an intimate partner may increase a person's risk for depression, PTSD, eating disorders, insomnia, substance use, and suicidality, as well as chronic health conditions, including chronic pain, all of which have implications for the opioid epidemic as well. In population-based studies like the CDC NISFAS study found that 52% of women and 17% of men who experienced intimate partner violence reported PTSD symptoms, and 73% of women and 35% of men reported at least one negative impact, including fear, concern for safety, missing school or work, or needing services. So tremendous impact on people's lives. Other studies have found high rates of depression, PTSD, and suicidality among women who are accessing domestic violence shelters. So in addition, exposure to ongoing abuse can exacerbate symptoms and precipitate mental health crises, making it more difficult for survivors to access resources and increasing the amount of control an abusive partner has over their lives. Some of these symptoms or conditions are the direct result of physical and sexual violence, while others are related to the traumatic psychophysiological effects of ongoing abuse. And for some survivors and their children, these resolve with safety and support, but for others, accessing both trauma and DV-informed mental health and substance use treatment services is critical to their healing and recovery. One of the unique aspects of domestic violence that I'm assuming that many of you are aware, but not all of you, is that in addition to experiencing the traumatic psychophysiological effects of abuse, many survivors experience coercive tactics that are specifically related to their mental health or use of substances as part of a broader pattern of abuse and control. For example, while survivors of domestic violence may use substances to cope with trauma, abusive partners may also force or coerce them to use. So, in fact, those of you who are working in the mental health and substance use fields may or may not be aware that domestic violence is often targeted specifically towards undermining a partner's mental health or substance use disorder treatment and recovery. And these are some of the data from two studies we did with the National Domestic Violence Hotline I'll show you in a minute. The pair of studies showed really disturbingly high rates of abuse that specifically targets a partner's mental health or substance use. Callers reported that their abusive partners intentionally did things to undermine their sanity, prevented them from accessing treatment, controlled their access to medication, sabotaged their treatment and recovery efforts, and then used their mental health or substance use condition to discredit them with friends, family, helping professionals, and the court. So here's the data from the two studies that we really see as groundbreaking studies. These are things that we've heard from survivors and from advocates for many, many years, and this was the first large-scale quantitative study. We did this in 2012, and the hotline graciously does what they call focus surveys at the end of a call if someone isn't in crisis and often wants to participate to be helpful to other people who may be experiencing similar things as they are. So this was over 2,700 callers. 86% said that their partner or ex-partner had called them crazy or accused them of being crazy, but 74% said their partners deliberately did things to make them feel like they were going crazy or losing their mind, or like gaslighting. And of the 50% of people who had sought help, 53% for being upset or depressed, almost half said their partner had tried to prevent or discourage them from getting that help or from treatment. And people would talk about their partners showing up in treatment and trying to control the discourse, controlling their meds, preventing them from taking meds, forcing them to take an overdose, and then having them committed for taking an overdose, and then using all of that to threaten their ability to maintain custody of their children. Similarly, the substance use coercion study that was over 3,000 callers, as you can see, 26% of callers, and these are not people who are in substance use treatment, these are callers to the DV hotline, National DV hotline, said that they had used substances at some point to reduce the pain of partner abuse. 27% said that they had been pressured or forced to use alcohol or other drugs or made to use more than they wanted. And of the 15% had sought help for substance use, 60% of those people, those callers, said their partner had tried to discourage them or prevent them from getting help. And we would hear stories of people being prevented from attending meetings or treatment, being harassed into leaving treatment, having a partner withhold transportation and financial resources, keeping substances in the home, forcing a survivor to use after they come out of a treatment program, or forcing them to watch their partner use, and then again threatening to discredit them with Child Protective Services or in the courts with custody hearings. We also heard some of the things that we've also heard from survivors, not from this study in particular, is really particularly relevant to the opioid epidemic, of introducing a partner into using opioids, facilitating their becoming physiologically dependent on opioids, and then controlling their supply and using that to further control them, including coercing them into engaging in illegal activities, whether it's stealing or dealing drugs or engaging in sex work that they would not want to be part of otherwise. Entrapment into trafficking is another result of this. And then using opioid history as a threat to prevent people from maintaining custody of their kids. Another thing that we've heard abusers do is, coerce a partner into using, getting them high, then videotaping them, and then using that against them in custody hearings, or threatening them with withdrawal or preventing them from being able to participate in things that they need to do to maintain their work, their jobs, their schooling, their housing, or other things that are important to them. We also know that people who perpetrate domestic violence actively try to undermine their partner's relationships with their children, which creates risks for their health, mental health, and well-being. And while we know that exposure to intimate partner violence can impact children and increase the risk for child welfare involvement, particularly when DV is compounded by parental substance use or mental health conditions, research has consistently shown that attachment to the non-abusive primary caregiver is what's most protective of children's resilience and well-being. So research cited by the Child Welfare Information Gateway has also shown that prevention and early intervention efforts are very effective in reducing child abuse and domestic violence, and there are lots of resources listed in the information memo that can support and help families who are struggling with these issues, that both support the person who's being abused and their parenting and attachment. So as you can see, experiencing a mental health or substance use condition really increases a person's risk for being controlled by an abusive partner. And we talk about risk rather than vulnerability to make clear that this isn't something that's inherent to the person being victimized, but it's the stigma that's associated with mental health and substance use conditions that reinforces the ability of abusive partners to get away with using these tactics. And for example, like we think about someone who may have a psychiatric advance directive, thinking who is the attorney, in fact, who's controlling their choices about treatment. If we're obtaining collateral information for someone who comes to an emergency department for a suicide attempt or is having an acute mental health crisis, who are the people that we ask for that information? Family member involvement, making sure that they're not abusive, and thinking about how the stigma plays out in custody hearings and Child Protective Services, and really thinking about if a partner is bringing this up as an issue, to have that be a red flag that there may be coercion going on. So thinking about the unique condition, the unique considerations for thinking about this particular intersection, many state mental health and substance use disorder treatment systems have really successfully implemented trauma-informed and trauma-specific treatment and services with a lot of progress and advancement in those areas. However, while awareness of trauma has increased over the years, trauma in the context of domestic violence, thinking specifically about coercion and safety, often has not been specifically addressed. So that's why understanding these intersections is really critical for clinicians who are working with people who've experienced both past and ongoing abuse. Knowing how to respond appropriately when someone's experiencing immediate danger or contending with an abusive partner who's trying to control undermine their mental health or sabotage their recovery is really critical. I mean, just thinking about how do we layer that in to all of our services, our policies, and our practice. You know, like most clinicians report they'd like additional training and resources on how to respond to domestic violence. Many haven't received that yet, and that's part of what we're hoping to promote with the launch of the information memo and with the resources that we'll provide and with a webinar series that we'll be developing over the coming months. Similarly, many DV programs report challenges in accessing resources and serving survivors who are dealing with more complex mental health and substance use-related needs, and forming those partnerships at the local level and at the state level is really critical. I just want to touch on, and not go into detail, there really are, Melinda, you talked about the importance of evidence-based treatment, and there are numerous evidence-based treatments for PTSD, but again, the majority of those focus on trauma that's occurred in the past. And so when we're thinking about the context of ongoing domestic violence, the trauma is often unremitting, and the symptoms may be a response to ongoing coercion and control. So I just wanted to highlight there are a number of evidence-based trauma treatment modalities specifically adapted for survivors of domestic violence, and a number of others that were not designed for domestic violence but have been used successfully in the context of domestic violence. There are also, similarly, in the substance use disorder treatment field, there are a number of gender-responsive, trauma-specific substance use treatment modalities that, again, have been used successfully with survivors of domestic violence, as well as interventions specifically for children who are exposed to domestic violence that support their parents. So I already talked about that here. So again, just to kind of wrap up this part, it's really, when we're thinking about mental health and substance use disorder treatment in this context, it's really a combination of DV-specific approaches that can be incorporated into any treatment modality that's effective for a given survivor. Domestic violence is not a psychiatric condition, so it's not like there's a one-size-fits-all approach. And adding in trauma-specific treatment modalities that have been developed either specifically for survivors of domestic violence or successfully adapted, which means addressing ongoing risk, addressing cumulative effects of trauma across the lifespan, including collective forms of trauma, and also thinking about culturally specific modalities that are really resonant for people who come from particular communities that other traditional modalities may not be what's going to be most helpful. And those, again, exist in the world and don't have the same evidence base. And part of this work is to make sure that those are part of the mix, because often those are what are most healing and most helpful to people. So I'm going to turn it back to Kenya.
Yes, thank you so much. Thank you for going over that information, Carol and Dr. Warshaw. It was extremely informative and really helped give great context to what we're talking about today, and the purpose for the information memo that Melinda from SAMHSA will be talking about in a moment. So what we really are excited about is that this creates a vast opportunity for there to be ongoing collaboration and to utilize the expertise that's available from domestic violence advocates that are there in your local community. Oftentimes when survivors of domestic violence are coming in for treatment and for services and supports, they also have other challenges that are very specific to the abuse that they've been experiencing that advocates are very well equipped to support and to handle. And so when survivors are able to reach out to local community-based programs, they're able to go in for assistance with in-depth safety planning. So that may not only be safety planning around safe housing options, but also how to safely access treatment, how to plan for ongoing safety related to any legal issues they may be following up on, as well as childcare and things of that nature. They can also get advocacy support around economic stability, workforce development, job training, and things of that nature. There are opportunities for their children to receive services. Oftentimes in most domestic violence programs, they're concurrently providing services to the adult victim of domestic violence at the same time that they're providing services to children, teens, and youth who may also be in shelter or accessing services with their victim parents. And then they can also work with the survivors to help plan for their long-term housing needs, whether that's through transitional housing, DV Housing First, or some other form of housing support that might be available to them. And then, of course, accessing programs for teens and youth. So a lot of programs will do aftercare. They'll follow up with mentorship, but also really wanted to make sure that teens have access to supports that they may need to recover from what they've witnessed, and to also help them understand what healthy relationships look like and how to set boundaries, as well as to know how to get the help and support they may need as they're processing what they've witnessed and what they've experienced. And then also a lot of domestic violence programs have many collaborations with other community partners. And so being able to help access those various systems that can really support survivors and the multitude of challenges that they may face can be really helpful as they're also seeking treatment for any substance use disorder, any mental health needs, and to also help maintain any sobriety. So in large part, that's what we're really calling for here, is we're looking for greater collaboration, not only at the state level, but also on the local level, where these service systems can really pull together and work together to address the unique challenges that survivors face, particularly around substance use and accessing mental health services. So we really want to underscore that the collaboration among the service systems, such as cross-training, developing protocols, understanding how each system works and the system of care that's available, is really instrumental and vital to helping survivors maintain economic self-sufficiency, to become sober, to remain sober, and also to get support for their children. So we want to ensure that through the tenets that we're proposing in the information memo, that we're responding effectively to individuals who are experiencing these crises and these challenges. And so oftentimes this does require specific training and support, as well as ongoing relationships across programs and between disciplines. So I want to pass it over to my colleague from SAMHSA, Melinda, to talk a little bit more about the background and the context for the information memo.
Whoops, sorry, we were on mute here. So one of the mechanisms that the federal government has to address what the field has identified as critical issues is through an information memorandum. And so in an informational memorandum, we try to identify those critical pieces that we've identified from this vantage point to help folks in the field to identify the issues in their particular communities. And so in order to address this intersection that Carol, you so aptly pointed out, SAMHSA and ACF has come together to issue this particular information memorandum. And so in it, we have laid out some critical pieces of research, resources that are very important, and also recommendations for state and local providers and systems. And so the purpose of it, next slide, please, is to provide both, as we think about folks in the field, we're often in silos, as you so well know, but to provide state mental health and substance use disorder treatment directors with information about domestic violence, including its prevalence among individuals that they're already servicing in their mental health and substance use disorder settings, the evidence of the impact of domestic violence, and so how it contributes often to substance use and mental health challenges, and also making sure that folks are aware of the available training, resources, and potential partners in their communities for developing effective responses to the individuals and families that you're already seeing in your organizations. And so, Kenya, in terms of the State Family Violence Prevention and Service Act administrators, we hope to use that information about the mental health and substance use effects of domestic violence, and also to point out the available training. And Kenya, I don't know if you want to address that further.
Thank you. My apologies, I was on mute. No, you're absolutely right. We want to make sure that our FIPSA state administrators have a sense of what's contained within the information memo, that you're very familiar with the intersection of these issues, and that you can then work not only with your state domestic violence coalition, but also with the programs that you're funding through FIPSA dollars. We think it's important to ensure that there is availability of training, that resources are developed around these intersections, and that we're seeking out potential partners who can really work effectively at these intersections. And this may mean that we're looking for non-traditional partners that have been allies with us in this work, but we also just want to make sure that state administrators, as you're looking through the information memo and considering ways to implement some of the recommendations that are there, that you're really thinking creatively about how to pull together systems and weave together funding to best support survivors in a number of different ways. So next, we're going to have a couple of states come on the line and talk about some of the successes that they've seen after we go through this next slide here.
Thanks, Kenya. And so just to kind of drill down a little bit, it's important for state mental health and substance use treatment directors to think about implementing strategies at the individual participant consumer level, knowing that often the individuals that you're seeing already are experiencing interpersonal violence, but also thinking about the knowledge and skill training that you can provide for your frontline clinicians about these issues. So really encouraging folks working in your organizations to be able to get that training, but also looking at the policy changes that need to be made to, incorporate responses to domestic violence into your state and local community policy and practice levels, so individuals can be safely linked to domestic violence services. But the other piece is also looking at, from a larger level, how can state policymakers think about encouraging and also perhaps making policy changes to allow those intersections to happen more naturally and and break down some of those silos. And especially developing partnerships with the SAMHSA administrators in your state, territories, and tribal domestic violence coalitions.
Absolutely. One thing that we're looking at is wanting to make sure that you certainly are working with your programs and encouraging them to provide trauma-informed, culturally relevant services to all victims who come in seeking services, as well as their families. And I believe a couple of our next presenters will talk about some of the work that's happening in their states that's really effective. But we want to make sure that we're promoting, to the extent possible, two-generation approaches, that we're seeking out programs that allow survivors to have their children with them while they're seeking services. And so for us, that really does mean that we're taking a look at how can we serve all survivors of domestic violence and their families in order to best meet their needs and ensure that we have low barrier access for services, emergency shelter, and other types of support that will really help them heal and recover from the abuse and the substance use they have. We also want to encourage training on mental health, substance use, and trauma-informed best practices, some of which you will hear about on this webinar today, but then also thinking about ways to be innovative based on the unique needs of your community and what that looks like. And we want to ensure that we're fostering collaboration across and between service providers in your state. So now we're going to hear about what are some of the ways that this can work. And I think Dr. Warshaw is going to introduce our next couple of presenters.
I am. Thanks, Kenya, and thanks, Melinda. So I'm going to introduce Beth Collins, who's a domestic violence program specialist at the Division of Children, Youth, and Families in the Colorado Department of Health and Human Services, Department of Human Services, which is where you work at the office that is the SAMHSA Administrator Office, and used to formerly at the State Domestic Violence Coalition, and Beth's going to talk about an initiative that we worked on together with the State Behavioral Health Department, and Elliot Burkhead, who is the Deputy Commissioner of Programs and Policy at the West Virginia Department of Health and Human Resources Bureau for Behavioral Health, and Elliot's going to talk about a partnership with the West Virginia Coalition Against Domestic Violence that's been going on for many, many years. So I'm going to turn it over to you first, Beth, and let me know when to move your slides.
Wonderful. Thank you, Carol. So yes, this is Beth Collins. I use the pronouns she, her, and hers, and as Carol mentioned, I work for the Domestic Violence Program here at the Colorado Department of Human Services. I'm really honored to spend a few minutes with you to share an example of what are some small steps that can be done for state agencies even before there are any specific resources being devoted to a collaboration. So the Domestic Violence Program, or DVP, where I work, we are the ones who administer the PHPSA funds for Colorado, and to 45 anti-domestic violence organizations. Those organizations have for many years been asking for more information and guidance regarding the intersection of domestic violence and substance misuse and addiction. So what I will touch on first is the relationship building that we have been doing with our peers at the Office of Behavioral Health. So I joined the Domestic Violence Program in 2016, and through my prior work with the State Coalition, I had met Carol from the National Center on Domestic Violence, Trauma, and Mental Health, who we've been hearing from. Thank you, Carol. And through her national work, Carol also knew someone I didn't, who was Carol Mooney, the woman who was working as the Women's Substance Use Disorder Treatment Services Manager here at Colorado's Office of Behavioral Health. So Carol suggested that Karen and I connect, and so we did. And we discovered a common goal to better support advocates and treatment providers in addressing substance use coercion and domestic violence. So Colorado's collaborative efforts truly began through these individual relationships. So through the initial conversations that we had, we were able to invite one another to present to each other's advisory group and service providers group, and eventually we were able, when Carol with the National Center reached back out to Colorado in the summer of 2018, we were eager to say yes to piloting this toolkit, so the National Center Toolkit on Coercion related to mental health and substance use in the context of intimate partner violence. So the pilot consisted of 8 participating OBH-funded sites, each of which was provided with toolkit materials to bring to their work setting. The participants joined a 90-minute web meeting led by the National Center staff once a month for 7 months, with the purpose to review the toolkit and to discuss barriers or successes with how the toolkit materials were being used. DVP staff informed the anti-domestic violence organizations in each of the 8 communities where the pilot project was happening that it was underway. And OBH encouraged the pilot sites to make connections with their local advocates. In addition, a local advocate presented to the group on advocacy practices and safety planning, and our State Coalition Against Domestic Violence gave the pilot sites access to their online training. In these small ways, a network is slowly being built here in Colorado. As a result of the pilot, DVP and OBH have continued to build a working partnership, and we're learning more about the on-the-ground work protocols that can help or hinder in terms of screening, referrals, and local connections. Also, as a result of the pilot, DVP has been more mindful about the ways that substance use complicates the experience of surviving domestic violence. We have also had more awareness of and have promoted through our communications the OBH public health campaigns, including their Lift the Label initiative. Through our relationships with OBH, we have also learned that anti-domestic violence organizations in Colorado would qualify as harm reduction entities and thus be eligible for no-cost Narcan kits, which OBH has purchased with federal opioid response funds. In partnership with our state coalition, known as Violence Free Colorado, DVP has released a template for local anti-domestic violence organizations regarding policy and protocol for working with people with behavioral health concerns. DVP is also working with Violence Free Colorado on advancing training, technical assistance, and other supports for enhancing accessible, culturally relevant, and trauma-informed advocacy practices here in Colorado. So in summary, some suggestions to other states that may not yet have a solid PHPSA administrator and behavioral health partner relationship. We would say first, reach out across offices or departments to build that individual connection and discuss common goals and overlapping populations. connect those common goals to the federal and state priorities, to ensure that there are ongoing conversations, particularly throughout inevitable staff transitions. We found it useful to have a small-sized initiative to work on together. So the pilot of the toolkit did not require any funding, and it was also a small enough time commitment that we were able to fit it within existing work plans. And then learn together, so just be curious in this uncharted work for the state. And it's been really very useful here in Colorado to see how it continues to branch and the interest and the partnerships that are continuing to grow. So by starting small and building relationships and amplifying the value of one another's work, Colorado is currently much better positioned to potentially be able to go after additional project resources in the future. So starting small, it does grow, and we've been very thankful for the support of Carol and her team throughout our efforts here in Colorado. And with that, I will now turn it over to Elliot Burkhead, JD, so that we can learn about the more advanced collaborative work that's happening in West Virginia. So Elliot, the microphone is now yours.
Hi everyone, this is Elliot Burkhead. I work for the Bureau for Behavioral Health, and we're part of the larger Department of Health and Human Resources agency in West Virginia. By way of background, Lori Thompson, who is my erstwhile colleague on this effort, started working with her colleagues on bringing mental health and domestic violence together back as far as 2001. Their initial approach really involved meetings on how to figure out how to address mental health issues with survivors and how to develop trauma-informed approaches to services. So the initial partnership with us, I had a staff person assigned at the time. I was then running the Adult Behavioral Health Division named Barbara Edmonds, who was our liaison to the coalition. And she and Laurie brought us basically a proposal to do an initiative beginning in 2007 in which they would bring in consultants from the National Center on Domestic Violence, Trauma, and Mental Health, more specifically Dr. Warshaw and Dr. Terry Pease. And the outline of the plan broadly involved essentially bringing together our state domestic violence agencies as well as our state comprehensive behavioral health centers. So we had a series of multidisciplinary meetings to start the process up, and then somewhere along the line we were able to dig up approximately $50,000 in mental health block grant money provided to us from SAMHSA. And at that point, we were able to establish a plan, and really Laurie and her folks get all the credit for this because they were the implementers and we were more the assistants. But they coordinated an initial 5 regional meetings that would bring together mental health providers, legal service providers participated in that, as I understand it too, and domestic violence advocates. Later, 3 more additional trainings were added so we could cover a broader region of the state. And that sort of has led from there to ongoing initiatives that Laurie and other representatives of the Coalition Against Domestic Violence have participated in at the policy level. So that included initially, we had a legislatively created comprehensive behavioral health commission specific to mental health that Laurie specifically was given a seat on. Subsequent to that, we had, obviously, as all of our states have been faced with addiction, we formed a Governor's Advisory Council at that time called GACSA on SUD issues. That also led to system issues, and Laurie also was given a seat on that group. And now there is a ongoing strategic planning initiative happening around the state that our newly developed Office of Drug Control Policy has put out. And that's been basically regionally set up and structured, and Laurie and others from the coalition are going to be participating in those meetings too. Basically, the take home there is that it's both important to have people involved at the local level talking to each other, as well as at the state level addressing system level issues. So on the next slide, that takes us into sort of the current plans, which in this case really involves funding made available through our sister agency, which is basically the child welfare organization in our state called the Bureau of Children and Families, that has made funding available for behavioral health work kind of continuing what was started through us and the Coalition Against Domestic Violence. And they're specifically looking at health issues. They're also, interestingly, partially funding Lori's position as the Health and Behavioral Health Coordinator at the Coalition. And beyond that, Lori is also going to lay the groundwork for the next round of basically community cross-training opportunities by meeting with our Behavioral Health Providers Association. I'm sure there's one in every state that represent the publicly funded behavioral health providers, which is how we kicked it off last time as well. Her plan this time, as I understand it, is to do 8 regional trainings on the intersection of SUD, coercion, trauma, and domestic violence beginning next spring. 4 will be specific to domestic violence advocacy programs, and 4 will be regional comprehensive behavioral health center representatives. And then coming forward from that into 2021, the funding from the Bureau of Children and Families will be used to basically bring those groups together again and talk about some cross issues. In terms of the impact, the main thing is that this was an opportunity really to bring the players together at both the state level agencies together and then the local agencies together to basically see what each group faces. I certainly remember vividly that there was a fair amount of stigma on both sides. People on the DV side didn't necessarily want to deal always with behavioral health, and the behavioral health counterparts didn't always want to recognize DV and trauma. One of the things that was a real benefit was the work that Dr. Warshaw and her colleagues brought was basically evidence-based approaches to use with people in both systems, in the behavioral health and the domestic violence systems. So, for example, the CBHC staff, the behavioral health staff, learned how to assess and refer people to domestic violence providers, and the domestic violence providers learned how to assess and refer people to mental health providers. In both cases, this has led to better services and an enhanced understanding of the impact of trauma. Lessons learned, the big one for me, the big take-home is that cross-training can't be a one-time event, especially in a small state like ours. People retire, they change positions and leave jobs. So the training really needs to be redone periodically at regional and local levels. Important deliverables is that ongoing cross-referral and service development happen at the local level, and that's probably the most important level. It's nice that the state level folks talk, but it's even more important when the county agencies are able to talk to each other, the regional agencies able to do that when they identify either issue. There's also certainly something to be said for the fact that generally it's not necessarily a given that when we, the behavioral health agencies, set about our business of doing systemic level planning and strategic planning, we don't necessarily always include the DV voice. And unless we invite them, that's not going to happen. But all of you who are my counterparts can make sure that happens. And the final thing is just bear in mind that block grant funds do give you the flexibility, both on the mental health and SUD side, to fund these kind of initiatives for cross-training and education and bringing people together. And especially, like in our case, we had unexpended dollars close to the end of the fiscal year, and one-time funding for activities like this are really worthwhile. So that's all I have, Dr. Warshaw.
Great. Thanks. It's really wonderful hearing both of you talk about your work, and I hope that's inspiring for for those of you who are from states where you haven't started doing this. And if you are doing this, we'd love to hear from you because we'd love to highlight your work in future webinars. So, Gabriella, do you want to do a little bit of Q&A? We still have many more slides, but if there's some questions right now that are pressing, we could take a moment and discuss some of them.
Yeah, that'd be great. So there's one question that came in. It says, our agency is diving into training nurses on how to screen for domestic violence. Any resources that you would recommend on screening tools, as well as how to navigate any kind of mandated reporting requirements?
So, well, you know, there are screening tools, but one of the things that we recommend is actually having conversations with people in private settings where it's safe and there isn't clearly not an abusive partner present. Our coercion toolkit that Beth showed, and we have another slide later on, has a lot of guidance about how you could bring up questions around domestic violence and coercion in the course of doing an intake or an assessment, probably better in an assessment. The intake part is important in terms of initial safety issues issues that may come up while somebody is in your site, if there's an abusive partner with them. So we have that. We also have, there's a resource that we developed for the National Suicide Prevention Lifeline that was in partnership with SAMHSA a couple of years ago that have questions you could ask, like if you're taking a crisis call, to make sure that it's actually safe for the person to answer and that someone isn't standing there who's monitoring their call. So we can provide information about tools and resources. And we have information, the link on the earlier slide about our center, we created a new web page that for mental health and substance use disorder treatment providers that has a lot of resources there, but we will also be developing new ones over the next couple of months.
Thank you. And then another question, any tips in getting mental health and substance use state programs to be more motivated and inviting domestic violence people to the table? In our state, they'll come to us if we're hosting trainings, but we don't see it go both ways.
Dr. Elliott, do you have would you want to respond to that?
Hi, this is Elliott. I think, again, modeling that behavior, at least for us at the state level, was really helpful. And it seemed like gradually, not all, but many of our regional partners took to that. And one of the things that we did that was particularly helpful is one of the things I mentioned is having the equivalent to Laurie, the person that's the leader on the domestic violence side, come and speak directly to their association. And do that in concert with a counterpart on the behavioral health side. So Laurie and I did that together with the Providers Association with the full support of our then commissioner, and that carried some weight and clout. And what we did is we ended up with a couple of real passionate advocates in the behavioral health side who really helped us lead the way on that initiative.
Great, thank you. And we've had another question come in. So for states that do not yet have a model such as the one that Colorado utilized, do we have resources to aid in the initial processes for other states to reference?
So, Gabrielle, I'm not clear what the question is. Can you reframe that?
Sure. So my initial thought is whether there is any kind of blueprint or best practice guide available around how to start some of that initial groundwork for states who don't yet have a framework or those relationships in place. And if I'm misreading that question, please feel free to type into our question and answer box any clarification pieces. But something that comes to mind for me is at the National Center on Domestic Violence, Trauma, and Mental Health. That's actually a project that we'll be taking on and really supporting different collaborative endeavors at the state level. And so we hope to, in the near future, to actually produce some resources and aids for state agencies that are interested in taking this on.
Also, Sandel, there was a multi-site initiative that we did, I think it was from 2008 to 2011 with 8 states, some of which formed partnerships. I think West Virginia was one of them, with their state behavioral health partners. And we have a report on our website, and I can look for it and make that available with the materials that we send out after the webinar. And we will be developing more guidance and an initiative to kind of support and nurture this going forward. So if you have a particular interest, then please reach out to us, any of you who do, so we can start working and finding ways to support those processes.
Great. And then I'm not sure if any of our speakers can speak to this question, but I'd love to hear thoughts. Any thoughts on the potential role of state Medicaid programs and or Medicaid MCOs in facilitating this level of collaboration?
I'm just going to jump in. Well, if someone else has more up-to-date information, we had a project went from 2004 through 2011 that was actually funded by an OVW disabilities grant, where we were working on an initiative around survivors of domestic violence and sexual violence who were living with a psychiatric disability, and someone from our state Medicaid office was one of our was a partner, a collaborative partner, and helped us think about ways that we could potentially use some of those funds to support cross-sector work. One idea was being able to use funds to support recovery support specialists who, or community support outreach workers who were able to provide services at a domestic violence shelter, because people in domestic violence shelters were considered homeless, and so the funds would apply to them so that people could be cross-trained and provide additional supports and services. So there are a lot of ways that could happen, and I think it's really about building those relationships and getting to know people, or finding out who can be a champion among your counterparts. I'm thinking we should go move forward and do the rest of the presentation and then come back to questions at the end. And we're happy to respond to questions afterwards as well. So, Gabriella?
Great. Well, yep, will do. So we wanted to introduce our partner guide as well as talk about next steps. So our partner guide is available for download on our website, and we'll provide that link here in the slide as well as in the chat. And so it provides an overview of the informational memo as well as strategies contained within the informational memo. There are also social media sample posts that you can copy and paste to share on any social media platforms, as well as different sample blog posts. There are infographics. Thanks. There are infographics available as well. I can handle the slides. Thanks. Okay. There are infographics available as well. So we hope that you will spread this information, these research findings, just to help raise awareness and help motivate and mobilize around this very important issue. And so to access the full information memorandum, here is a simplified link that you can follow. It's also available on the National Center on Domestic Violence, Trauma, and Mental Health website. And then here is the link to download our partner's guide. Our hope is that you will share this with your networks as well as your constituents. And this toolkit was mentioned earlier by Beth. Thank you so much, Beth. And it's available for download on our website. And it is a toolkit that can be used to help respond to intimate partner violence concerns and mental health coercion, substance use coercion. And it's specifically tailored for mental health, substance use, and primary care settings. And so here's a toolkit that you can download and start to just go through and see how you can ask some of those questions, create an environment of increased safety for survivors, and connect survivors with the services and resources that are needed for them and their families. Some additional selected resources here that you may find helpful. And then now I would like to turn it over to Dr. Melinda Baldwin for our closing remarks.
Thank you. And thank you to Beth and Elliot for sharing information about your programs. I think they are such good illustrations of the ACF and SAMHSA commitment to supporting state mental health and substance use disorder treatment directors, as well as state PHIPSA administrators and leaders in the domestic violence field to not only forge effective partnerships, but I'd like to emphasize what Beth talked about in terms of the importance of relationship building in forging those partnerships, to share expertise, but also understanding that that isn't a one-time event, and developing collaborative efforts, and knowing that that is an ongoing effort at the individual family level in terms of cross-referrals, but also, as Elliot pointed out, having leaders at the state and local level really help facilitate those commitments so that we can serve individual survivors, families, and children who are impacted by domestic violence. Next slide, please. So we encourage state mental health, substance use disorder, and DV agencies across the board to form partnerships at the state level to create opportunities for those cross-sector partnerships at the community level, but really taking into consideration the need for training and ongoing training, not just one-time events, the importance of good communication and relationship building, and also being able to set up referral processes that facilitate, really bringing experts in the different fields together to really help children and families. Next slide, please. And so just to quote directly from the Information Memorandum, if you can indulge me in just reading this because I think it's so important, that optimally serving individuals, children, and families affected by domestic violence requires that services incorporate the expertise of all fields, right, of mental health, substance use disorder, and domestic violence, while attending to those unique issues faced by survivors and their children. So from SAMHSA, we thank you for listening into our webinar this afternoon.
So, yes, and this is Kenya. I also just want to say thank you all for joining us today on this webinar and for hearing about this information memo. The work of the two great states that we heard from was really fantastic to hear and hopefully very inspiring for you. I know that there are a lot of questions about access to the links and the materials, and please know that that information will be forthcoming within the next week or so, and we certainly want to make sure that you're able to access a lot of the resources that Carol and her team are going to talk about in the next couple of minutes. And I think we may have a little bit of time left to take a couple of questions. So I'm just going to pass it back over to Carol and Gabriella, and they will lead us through the next few moments before we close out for today. But thank you all for being here. Thank you for the work that you do. And we really do want to continue to hear about the successes that you're having within your states and communities. So the information is provided here for the National Center on Domestic Violence, Trauma, and Mental Health. And we'd love for you to stay in touch with them, and they'll also continue to coordinate with us and share more information. So I'm passing it now back over to Dr. Warshaw.
So I'm going to highlight a few of the resources we have at the end of the PowerPoint presentation. And then, Gabriella, if there are more questions, we have a little bit of time. This might be a first, actually, having enough time at the end for questions, at least for me. Anyway, so these are some of the resource centers and technical assistance for coalitions for those of you working in the mental health and substance use disorder treatment field. There are lots of resources also for those of you working on the DV side of National Association of State Mental Health Program Directors and the National Association of State Alcohol and Drug Abuse Directors. For those of you who work in the DV field, you may not be aware that many states have the substance abuse block grants from SAMHSA have a special carve out for women's services, and many states have a women's services coordinator. That's who Beth was referring to, Karen Mooney, who was the person involved when we first started. So that's often, and we recently did a survey with NASADAD, and there are many states that where the women's services coordinators have a strong interest in partnering with DV coalitions and their DV partners at the state level. And the TA for state mental health directors and state substance use disorder treatment directors by SAMHSA's TA tracker. And there are also the national DV hotlines, including the dating abuse hotline, the sexual assault hotline, and the Strong Heart Native helpline, if those resources are available and can connect people to services. So I'm going to go back now that we've shown you the resources to our question slide. So sit here for a little bit, close your eyes, and let's see if there are other questions that you have that we can respond to in the next 10 minutes.
So there's one more question that's come in. So family court is often traumatic for domestic violence survivors. What's being done to address court-ordered reunification therapy and current research?
I don't know the answer to that. Shondell, is that something that you're familiar with, or Kenya?
Can you repeat the question? I'm not sure I understood exactly what was being asked.
Yes. So what's being done to address court-ordered reunification therapy in current research?
So we do, I believe, Shondell spoke about this earlier, and I believe also Carol spoke about it a moment ago. We do have a number of resource centers that are working on a variety of issues, which include working on child custody. And so we do have the National Council of Juvenile and Family Court Judges. They have a resource center on child protection and custody and the intersections with domestic violence. So I know that they are doing some work at those intersections and looking at what needs to change and what additional training and education needs to happen in order to improve services for survivors who are going through the legal system around child custody, but I can't speak right now very specifically to parental alienation. We do hear in a number of different ways that has come up as a key issue, and so I know that another resource center that we have, the Battered Women's Justice Project, they are also working on a national strategy to address some of the challenges and issues that are coming up related to child custody in the legal system. Because we do hear mixed things from our grantees. We hear about some of the challenges, of course, but then we also at times hear about some of the successes. So right now, those would be the best two resources that we could refer people to on this webinar, but I can't speak very specifically right now about parental alienation.
Another thing, I mean, there are a lot of DV programs and actually provide support for survivors as they're undergoing those processes, and some of the Family First work has been a way to support survivors who are not losing custody of their children. So there are a lot of people working in different areas trying to support both through partnerships with those systems. Some of the work we've done just in training of judges through the project at the National Council of Juvenile and Family Court Judges is raising awareness of how coercion may play out in child protective custody, child protective services hearings, and to think about what kind of support someone would need to be able to parent their kids, or to do safety planning around parenting if they are using substances, to make sure the kids are safe. And there's a program in Florida, Beacon House, that has done a lot of work in partnership in their community to support survivors being able to keep their kids. So there's innovative work happening, but I don't know about a formal process for addressing this.
Great, thank you. Those are all of our questions.
So, well, I want to thank you all for joining us today around these important issues. We'd love to hear from you about any collaborative efforts you're engaged in, including any ways we can support your work or highlight and share your work with others. In addition to the resources included in the slides at the end and on our website, as Gabriela mentioned, we'll be developing a variety of tools and resources to support your work at these intersections, including a new webinar series. I want to thank all of our wonderful presenters, to Melinda, Shondell, Kenya, Beth, Elliot, and Gabriela for today's webinar. And thank you to Heather for starting us off, and to Carla for making the webinar run so smoothly. And last but not least, we want to thank you all for spending your time with us at the National Center. Within the next week and a half, we'll send you all a follow-up email with a link to the recording of today's webinar, in addition to the slides and handouts referenced, all of which will be available on our website, as well as information about our follow-up webinars to support state and local collaboration. You'll also receive a certificate of attendance for your time today. And I know when Gabriela showed you our partner guide, we also have another set of materials that aren't on our website yet that include a set of 8 slides that you could use about the information memo in your presentations, and sample blog posts and media posts that we will send out with the materials that you can feel free to use to involve your counterparts and your constituencies. At the end of the webinar, you'll be taken to a very brief evaluation. If you could please take a moment to let us know what was useful and what could have been better, it would be greatly appreciated. Thanks again, and we hope you all have a wonderful afternoon.